Disclaimer: this podcast is only for informational purposes and not intended to be substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician with any questions that you may have regarding a medical condition, and never disregard professional medical advice or delay in seeking it. Hello everyone, welcome to my podcast, Dr. Lavi's Cup of Coffee. I am Lavi, a fourth year medical student and your host for this podcast. Today's episode will be a great integration of hemato-oncology, pathology and pharmacology, titled Ennie, Minnie, myelo Lover. Sounds interesting, right? Yes, it is interesting topic and it is yet very important for your NEET, NEXT, INSET, USMLE and also for your college exams as well. So hold up your cup of coffee, boost up your energy and let's get started. A 67-year-old man presents to you with a 10-day history of fatigue, bleeding gums, cellulitis, recent weight loss of 9 kgs. On physical examination, patient is pale but has no evidence of lymphadenopathy or hepatosplenomegaly. On this basis, can you guess what could be the problem of this old man? Before moving on further, can you guys tell me the normal values of WBC count, hemoglobin, hematocrit and platelet? Normal WBC count is 4,000 to 11,000 per mm cube. Hemoglobin in males is 13 to 16 gram per deciliter, and in females it's obviously low because of the menses, that is 12 to 15 gram per deciliter. Hematocrit in males is 40 to 54%, whereas in females it is 36 to 48%, and platelet count is 1.5 to 4 lakhs per mm cube. Let's move further. CBC was done for this patient and results are as follows. WBC count was high, that was 18,300 per mm cube, which consists of 75% blastocytes and 20% lymphocytes. HB was low, which was 9.1 gram per deciliter. Hematocrit was low too, which was 29%. Okay, so what's the most likely diagnosis of this case? Before making a diagnosis, check out the peripheral blood smear picture of this case which I posted on Insta and FB page of Dr. Lavi's Cup of Coffee. Pause the video, check out, come back and make the diagnosis and follow up the discussion. The most likely diagnosis is acute myeloid leukemia. Etiology for AML is genetic predisposition, radiation, chemical, occupational exposure and drugs too, which we will discuss later on. Can you tell which genetic syndrome is associated with AML? It's the Down syndrome, occurring in children less than 4 years, typically the acute megakaryocytic type AML associated with GATA1 gene mutation. Okay, next question. Which anti-cancer drugs can cause AML? It's the alkylating agents like nitrogen mustard, nitrosourea, platinum compounds like oxaliplatin, cisplatin, and what else? Topoisomerase 2 inhibitors like etoposide, tenofovir, etc. These two drugs are used for the treatment of solid organ tumors like ovary, breast, lung, colon, and even lymphomas. There are many genetic mutations associated with AML, and I will not go deep dive into it, and you can have a look on the pic which I posted on FB and Insta page. Talking about the clinical presentation, patient gives history of increased fatigue, excessive bleeding from the unusual sites, basically because of thrombocytopenia and DIC, and moving from head to toe findings. If the CNS is involved, there will be headache, vision changes, papillary edema, retinal infiltrates, and various neurological abnormalities, fever, tachycardia, and if we move on further down, there will be poor dentation and dental abscess, gum hypertrophy, mostly seen in monocytic type of AML, plus the skin nodules and the infiltrates, commonly referred to as leukemia cutis, and many more such things. Okay, so my next loaded question for you guys is, why did we encounter cellulitis in this patient despite the increased WBC count? This is because neutropenia was caused in this patient by the replacement of mature WBCs with the immature WBC precursors like monoblast, megakaryoblast, and other precursors, which decrease the immunity of the patient and increase the susceptibility to infection. As a clinician, what all lab and radiological investigations would you send for suspicion of AML? CBC with differential leukocyte count, clotting studies, viral serologies, CMV, HSV1 and 2, varicella zoster, biochemistry tests like electrolytes, creatinine, blood urea nitrogen, uric acid, LFT, RFT, amylase, lipase, etc., HLA typing, lumbar puncture in cases of CNS involvement, and most importantly, the bone marrow aspirate and the biopsy. What is the most characteristic finding in the bone marrow biopsy of the AML patients? It's the OR rods. What are the OR rods? These rods are just myeloblast cells, which are the WBC precursors, and they have eosinophilic needle like cytoplasmic inclusion bodies. Okay, which stain is used to see the myeloblast? The MPO stain or the myeloperoxidase stain. Which vitamin derivative is used for the treatment of variants of AML? It's the ATRA, all trans retinoic acid, a vitamin A derivative, which differentiates the promyelocytes into mature neutrophils, thereby inducing the apoptosis of the leukemic cells. MPO stain is the one which helps to categorize the various subtypes of AML. That's why it is very important. Going on to the treatment part, what all chemotherapeutic drugs can be used for AML? It's the antimetabolites like methotrexate, hydroxyurea, cytarabine, and many more. What else? Also the alkylating agents which we discussed above. Though they cause AML, but they are still used for the treatment of many AML variants. Bone marrow transplant and stem cell transplant are a great ray of hope for majority of the AML patients because it is a potential way to reduce recurrence and incidence of AML. Okay, that's all for AML today. Hope all this made sense. And if you really liked the episode or you have any questions regarding today's episode, then you can contact me on FB, Insta page, or even the question answer sections in Spotify, YouTube, or whatever app you are tuning in. Goodbye and happy learning.